Good afternoon. Thank you so much for joining us. We're so glad to be with y'all. Um, this is the Dementia lecture series, which is being provided by Cognitive Neurology here at Emory Healthcare in the Integrated Memory Care Clinic. I have with me, my name is Jenny Gay. I'm the clinical social worker for Integrated Memory Care, and I have with me my colleagues, Alice Cooper and Ashley Varner with Cognitive Neurology. And we have Dan Munster with us as well, but I will introduce him in just a moment. This series provides lectures that are relevant to topics that come up with the families and caregivers that we serve here in our clinics. It happens the second Wednesday of every month from 12 to 1 virtually. Please note that at the end of the presentation, we will answer questions. And you can put any questions you have into the Q&A, and they will be answered at the end of the presentation. And without further ado, I would love to introduce our speaker today, Dan Munster, an elder law attorney I've worked with for a long time and really admire and respect, and we're so lucky to have him with us today. I'm going to read Dan's biography briefly. Dan Munster received his Bachelor of Arts degree from Vanderbilt University in 1990. He went on to study law at the University of Detroit, where he was published on Law Review and clerked for the Michigan Supreme Court. Admitted to practice law in Georgia since 1994, Mr. Munster has invested nearly 30 years assisting Georgians with various elder care, special needs, and traditional estate planning matters. Early in his career, Mr. Munster had the opportunity to learn a great deal while working with the Senior Citizens Law Project, a division of Atlanta Legal Aid. In 1999, he founded the Elder Care and Special Needs Law Practice of Daniel D. Munster. While the firm's main office is located in Atlanta, Georgia, it represents clients across the state without regard to geographic location. Mr. Munster often delivers presentations to attorneys, financial professionals, and other civic organizations on topics related to his practice. His writings have appeared in various publications, including the Georgia Bar Journal. A passionate advocate for the elderly, Mr. Munster was named to serve on the Georgia Alzheimer's and Related Dementia State Plan Task Force in 2013. Mr. Munster is a member of the State Bar of Georgia, the Atlanta Bar Association, the Atlanta Estate Planning Council, the National Academy of Elder Law Attorneys, and finally, the American College of Trust and Estate Counsel. All of that to say, an extremely impressive professional, and we're so glad to have Dan with us today. And Dan, I'll let you take it away.
Okay, thank you. And thank you for skipping the last paragraph. I wasn't sure how you were going to, I should have narrowed that down and kept it a little shorter for you. Sorry about that. Thank you very much for having me, Jenny. I'm thrilled to be here and certainly to learn more about the Integrated Memory Clinic. And I'm going to go ahead and share my screen now as we get started, and then we'll sort of take it away. I understand I've got about 45 minutes, and so I'll try to manage that carefully. And at any point, y'all can just jump in and let me know if you need me to speed up or stop and answer a question, okay? So the topic that Jenny asked me to present on today, I think, is one which is front of mind for a lot of families who are caring for a loved one with dementia, and that is how to finance the cost of long-term care. Obviously, long-term care is a term of art that you might distinguish from skilled care, in the sense that long-term care is more of a companion, as you can see here, non-medical, custodial, personal services support, companion care, as distinguished from skilled nursing care, which would be things which doctors and nurses do, whether it be wound dressing or a feeding tube or physical therapy, things that might happen in a skilled nursing facility, which Medicare would cover. But Medicare does not cover the cost of long-term care. And so I'm going to go down that list of potential financing solutions in a second. But first, I wanted to highlight what exactly it is how to distinguish between long-term care and skilled care. I don't know how to mute my telephone, so hopefully my system will pick up that call and future calls quickly. Sorry about that. So in terms of what exactly it is, obviously we're talking about assistance with primary activities of daily living, dressing, bathing, toileting, transferring, and feeding. And as many of you might already have experienced, the first four on that list can arise at any given time, but almost always the part about feeding is the last one that I find that our clients end up needing help with. Also medication management, transportation, and then other items like laundry, grocery shopping, meal preparation, housekeeping, things that really relate to the idea that there are times when somebody really isn't safe to be alone and is not going to manage their diet, their nutrition and hydration, their general hygiene properly. And so that's kind of the time when we start to think in terms of needing help either from a caregiver, whether that be a spouse or an adult child, or possibly even a private home care company sending somebody in. That final bullet point, 70% of people who reach 65 ultimately require long-term care, comes from the link that's there. You guys have this presentation is available in a PDF format, so anybody who would like it, the Integrated Memory Care Clinic can provide that to you. So the next thing that I always try to highlight is the different settings in which long-term care might take place. And so the first one on the list, and these are kind of in the reverse order of least restrictive versus most restrictive, starting with nursing homes. 414 licensed nursing homes in Georgia as of this year, and 402 of them are dual certified Medicare and Medicaid, meaning that they provide both skilled nursing care and also long-term care. From a regulatory standpoint, the word the state uses for long-term care is called intermediate level of care. This is an extremely important point when I get down to talking about the myths that are out there, the urban legends, you might say, about Medicaid, is the idea that if someday mom needs help or dad needs help from Medicaid, then by definition that means the care that will be received is somehow inferior or deficient. And so I'd like to just take this opportunity to clarify that that's not at all necessarily true. When you think about it, 402 out of 414, that's 97%. So 97% of our nursing homes here in Georgia accept Medicaid. On that list of 402 nursing homes, there are good ones, there are average ones, and there are bad ones. No question about it. However, 97% of them accept Medicaid. And so the question really is not so much about whether your loved one might someday, or even yourself, I'm not sure where on the timeline we are in terms of the audience, but the question is really just, are you in a good care facility? Now, of course, beyond skilled nursing facilities, there are other places: memory care, assisted living facilities, personal care homes, independent living facilities, and of course, while you're still at home. And so the idea that somebody might need help with something like dressing or bathing or going to the bathroom or medication management or incontinence care, all of those things can happen in any of these different places. And so that's important to highlight, because when we get around to talking about the way to pay for all of this care, the answer is different when it comes to the different financing solutions and in which different settings they will or could add value. They don't all provide assistance across all of the different places that you see here on this slide. Something else I think is worthy of note, specific to this audience, excuse me. The second bullet point, memory care assisted living, for some reason, and it's probably logical, but in my mind, so, I learned the distinction so long ago, it's no longer logical, but memory care assisted living is just another level of assisted living, and it is not nursing care. That's a big deal because in Georgia, we don't have any Medicaid funding for any type of assisted living, whether it be memory care assisted living or assisted living in general. Over time, things can change. And so 10 years ago, our home-based program that I'm going to be talking about today was far less robust and added very limited value. And over time that changed, and I'm thrilled to talk about that. Now the focus has actually shifted, and the Council on Aging and other aging groups are advocating for Georgia to expand our Medicaid program into assistance with assisted living. But as of today, we don't have that. I'm going to, so a couple of slides later, I'm going to be distinguishing between Medicare and Medicaid, and I'm going to leave further comments about assisted living and Medicaid till we get there. So that's what long-term care is and the different settings that it might take place. In terms of the cost and why is learning about financing solutions so important? The answer is that the numbers get pretty big pretty fast. And so as you can see on this slide, the cost of care here in Georgia in the left column on average is anywhere from about $4,400 a month to $7,600 a month for home care, assisted living care, and nursing care. What is not necessarily apparent unless you have a calculator out is that by far the most expensive option is home care. So the number you see there, $4,385, is only assuming 44 hours per week. And so that's about 6 hours a day, meaning that somebody else, whether it be a spouse or a child, is responsible for care the other 18 hours a day. And so for somebody to receive 24-hour in-home care, the cost is off the chart, at least $15,000 to $16,000 a month. Of course, some people can afford that, and that's great, but most of our clients can't. And so somewhere around, especially post-COVID, now that the going rate out there from a private home care company is about $30 an hour, somewhere around 4 to 6 hours a day, you cross over into what it would cost for a nice assisted living facility. And so that option of in-home care for someone who's not eligible for Medicaid, somewhere around that point, you're going to cross into the question is going to arise, maybe we should be looking at assisted living, because at that point we have 24-hour care and meals, preparation and housekeeping, and a lot is covered in the $4,000 to $6,000 a month you might pay for assisted living. Not on this slide, but important for our audience today is the fact that memory care assisted living is more expensive than what you see reflected here. So in Metro Atlanta, the average cost for memory care assisted living is going to be about $1,500 a month more than the base level. The base level I typically see somewhere for somebody who's fairly high functioning and does not have dementia is you can have a very nice, comfortable assisted living setting for about $3,000 a month. You can also spend $6,000 a month if you prefer to have a concierge and somebody with white gloves bring you your meals. But the point is there's a fairly broad spectrum there of anywhere from $3,000 to say $6,000 a month. Those numbers all jump up by at least $1,500 a month once memory care is needed. So more like $4,500 to $7,000 a month for memory care assisted living. And once again, Medicaid does not play any role in payment for either of those types of assisted living. I guess one last point I would like to make about this slide is that there are often times when it's fortunate that we live in Georgia. One of them is now when the question is the cost of care, because you can see across the board, the cost of care in Georgia is below average. That doesn't mean care is below average. It just means that we pay less for it here. And so that's certainly a blessing. So here's the list I was talking about previously, and unfortunately, there are no more bullet points. There's nothing else on the list unless you want to add adult child's bank account. But the point is, what we're trying to do is look for solutions other than the client or the patient becoming financially destitute as a result of these costs of care. And so we want to look at what else might be on the list. The first thing that's not on the list, which I've included but then crossed off, is Medicare. As many of you already know, Medicare was never designed to pay rent for somebody to live in assisted living or even in a nursing home. Medicare will only provide modest help following a hospitalization of at least 3 days, and then maybe some in-home care, brief visits for skilled care, but it is not a solution for long-term care. Because this topic is so misunderstood, I'd like to diverge from long-term care as the focus for a second and talk about short-term care, talk about Medicare and how the post-hospital 100 days work, because there's just a great deal of misinformation and misunderstanding about that. The first point I would like to throw out on that topic is the difference between somebody being in the hospital inpatient versus being there for observation and observation status. A moment ago, I shared that following a hospitalization of at least 3 days, Medicare can help with post-hospital rehab. That's true. But if you don't have those 3 days, then no help at all from Medicare. And in addition, the 3 days have to be inpatient. So if somebody goes to the emergency room and is kept overnight for observation and then is later admitted for 1 day, that doesn't count, and your 3 days have not been met. So for whatever it's worth, and I realize I've got a bunch of medical people listening in, if they at some point want to add to this, but if you're ever trying to manage the care of a loved one in an ER or hospital and the word observation comes up, then my suggestion to our clients is normally to do everything you can to advocate for that person being admitted inpatient as opposed to being there for observation. The next point about this is just the idea of 100 days. If we were in a room and I asked everybody to raise their hand if they've heard about the 100 Medicare days, I would guess a lot of hands would go up. The distinction that I'd like to make, though, is that 100 days is what I like to say is a best case scenario, but it's not an entitlement, meaning not everybody actually gets 100 days following a hospitalization of at least 3 days. And so the way that works is that following the hospitalization, if somebody's admitted to a skilled nursing facility, then Medicare can help pay for up to 20 days in full and an additional up to an additional 80 days with a copayment that hopefully their supplement will cover. At any point during that 100 days, their skilled coverage can end. And the standard by which a determination will be made is the next point of focus that I'd like to make. For those of you who have the ability to write, or if you're obviously watching online, you can open another tab and go to the website medicareadvocacy.org. I'm a huge advocate for this website, medicareadvocacy.org. That is the Center for Medicare Advocacy up in Massachusetts, and they have a website which is a a gold mine of information about Medicare. So if you go there and you click on topics and you scroll down to the improvement standard, I would love for everybody participating today to go and read about that, because if you ever do have a loved one in a post-hospital rehab, or if you already have had someone in post-hospital rehab, it's virtually certain that you were told that the standard by which Medicare coverage ends is improvement or progress, and that if the patient is not improving, and instead if they have plateaued, then the skilled care will end. And so if you go to that website and you learn about the improvement standard and how it is not the correct standard, it will put you in a better position to advocate for your spouse or parent or loved one if they ever are in a skilled nursing facility receiving skilled care under Medicare, and you're ultimately told that the skilled care needs to end because they're no longer improving. From a visual standpoint, improving is an upward trending line. But what you'll find the law says, and what you'll read about there, is that the skilled care should continue if it's preserving the current ability or preventing deterioration. And so improvement is a much higher bar than those other two. This is not to say that everybody should get 100 days. A great example would be somebody, and I guess the way I explain this to my clients is, the older you are and the more cognitive impairment there is, and the more finite their ability to participate in therapy, there could come a point where they're no longer benefiting from the skilled care, and it will end within 100 days, and that's appropriate. It's just to make sure that I want to make sure you guys all know that the standard is not improvement, and you can go learn more about that at medicareadvocacy.org. Okay, so that's all I'd like to diverge regarding post-hospital skilled care and Medicare. The rest of the list, obviously private payment, then you've got long-term care insurance, hybrid investment products, VA benefits, Medicaid, both in the nursing home and the community care services program. All the way back up to the top under Medicare private payment, I showed you that slide earlier about the average cost. That number, 7,600 statewide, might very well be right, but here in Metro Atlanta, that's kind of the floor. And so there are actually places that are over $10,000 a month for private pay nursing care. And so it's important to be aware that the difference between paying privately and usually Medicaid can be thousands and thousands of dollars a month. And not many people can afford $100,000, $120,000, $140,000 a year for private pay long-term care. And that's why all these other options come up. In addition, and I'm certain the answer would be, 100% hands raised, nobody actually wants to go to a nursing home. And so for all of those out there saying, gee, I wish he'd stop talking about nursing homes because I don't want that, please understand I do get that. I acknowledge that. And my goal for all of our clients is to help them remain in the least restrictive setting, but also safe setting as possible. So that doesn't necessarily mean a nursing home, obviously. And so if there is a way for them to be in a less restrictive setting, then I want to help them help to pay for that as well. The third and fourth bullet points, those are probably not on the table for anybody participating in this session today, because you're here because you or someone you love has already been diagnosed with dementia, which means that it's too late for you to go and get long-term care insurance or a hybrid investment product that has a long-term care rider because of that pre-existing diagnosis. While that might be true for the patient, it isn't uncommon for the spouse of the patient or the adult child of my client to ultimately say, how do I take this issue off the table for me? And so for those who are younger and healthier and don't have a diagnosis yet, one of the things that you might want to explore with your financial planner would be whether there's an insurance product or an investment product out there that might help you to eliminate the need to explore whether Medicaid or VA would ever be an option because you've already covered it through private insurance. So once you remove Medicare from the equation, and once you eliminate long-term care insurance or a hybrid product because it doesn't exist, all that's left would be VA benefits or Medicaid. And so it's certainly true that I have helped many veterans over the years, but we're now kind of aged out of World War II. And I saw many, many more World War II veterans 10, 15, 20 years ago than I do now. And I'm actually now kind of aging out of the Korean conflict and beginning to see folks who served during the Vietnam conflict. And so, but there just don't seem to be as many. And there are also some requirements in terms of the VA regarding periods of war that make it harder to get VA benefits for somebody who served during the beginning of the Vietnam War. So this is the list. And I'm going to talk about each of the 3 final bullet points in greater detail as we go forward. I think we're about halfway through in terms of time, so I'm trying to manage my comments accordingly. So this slide relates to VA benefits, and as you can see, the first 3 bullet points are the 3 tracks that the VA will provide financial service on, or on which they will provide service. Right now, I'm not talking about the opportunity to go to the VA hospital or to get help from the VA with prescriptions. What I'm talking about right now is a paycheck. Okay, so the VA or the Department of Defense, depending, will issue a paycheck on one of the first 3 bullet points here. The retirement would be for a veteran who served 20 or more years and earned a retirement just the same as if they retired from IBM or Coca-Cola or any other private corporation. So that's basically a career serviceman. The second track, compensation, that's the word they use for VA disability. So if somebody has experienced a disability that is connected to their service, then they will be compensated for that financially. These 2 tracks, retirement and compensation, are not need-based. So if a veteran served for 20 years, then the retirement will be paid. If the veteran suffered a service-connected disability, then the compensation will be paid without regard to whether they have 50 million other dollars or that they have other significant income. They are not need-based. They're based exclusively on, did you serve 20 years or more? Do you have a service-connected disability? By the time somebody gets to me, and most likely everybody who's participating today, you know whether the veteran in question served 20 or more years, or whether they had a service-connected disability. And so there's not really any planning that an elder care attorney would do in this context. Having said that, there are times, and I do want to spend 30 seconds on this, that a veteran, especially Vietnam, will be experiencing some medical challenges which can be linked back to Agent Orange, and especially Lou Gehrig's disease and also certain types of dementia. And so depending on whether the person involved, why you're here, was a veteran, and whether they served in Vietnam, and whether they had any exposure to Agent Orange, all of that can translate into the possibility of a service-connected disability claim. I don't do any of that work, but I'd be happy to help you find someone if you have questions about that. Because they used some horrible chemicals during that war, and all of the people that were exposed to them, are now suffering the consequences of that. So certainly explore that. The program, the 3rd bullet point, the program that I wanted to spend a minute talking about is most commonly called aid and attendance, but it's really the wartime pension that is paid out on 3 levels. The term for those 3 levels are these words here. I guess I can't highlight without changing the page, but the base level, housebound level, and aid and attendance level. Down below, you can see the three payment amounts for aid and attendance. The first amount would be the widow of a veteran, $1,432 a month. Second payment, which is amazing, it's this large. There have been huge increases over the last 2 years because of inflation. Over $2,200 a month for a widowed veteran, and over $2,600 a month for a veteran with one dependent, basically a married veteran. So these numbers are important to keep in mind when we're talking about assisted living, because earlier I shared with you that we don't have any Georgia Medicaid assisted living. It's not uncommon, though, for somebody to have income somewhere within $1,400 to $2,600 of what it would cost for assisted living, but they can't otherwise afford it. And so being able to get an extra $1,400, $2,200, or $2,600 a month can mean the difference between the ability to afford a nice assisted living facility or not. So the VA program in Georgia provides the greatest leverage and help in the assisted living setting, going back to that list of different settings. In order to qualify, actually, I did not update this number, 138. It's now closer to 150. I apologize for that. But the veteran had to have served at least 90 days active duty, at least 1 day during wartime. He must not have been dishonorably discharged. And there must be either the couple or the applicant, whether it be a widow or the widowed veteran, must have a net worth below a certain total. For the sake of today, just assume 138 equals 150. And again, I apologize. I thought I caught that. Important is that the VA, unlike Medicaid, includes in that net worth the value of somebody's monthly income for 1 year. So if somebody has monthly income of $3,000, that's $36,000 that counts as part of the $150,000 net worth. People often overlook that, and so I want to highlight that. The final bullet point is also important, and it's designed to help folks understand, or really requires, that you can't just get this paycheck so you have more money to live and have a nicer car and travel and so forth. This is a program that is designed to help veterans and their widows afford the cost of their medical expenses, which are otherwise consuming their income, such that their modest savings are circling the drain. And so in order to qualify, you actually have to show that you have medical expenses that consume your income. For many people, that's not really possible if they've got $2,000 or $3,000 a month of income, if the only medical expenses they have are their prescription copays and their insurance premiums and so forth. However, the cost of assisted living and the cost of unskilled companion care at home through a licensed home care company can count for that. Now, I have to be careful about the specifics I go into during a session like this, especially which is being recorded. Understand that the definition of medical expense is not something that you should consider closed at this point. I think that you should look into more what that includes. People often ask, well, what about if I'm paying my daughter, paying a family member? What if I'm not using a licensed, bonded, insured company? I'm just paying somebody from church under the table. There's all kinds of different levels of analysis that have to go into that. But ultimately, if you can show income which exhausts your income, then that's when the VA payment would be triggered. Moving along, because time is limited, we're going to next talk about Medicaid and distinguish between home Medicaid versus nursing home Medicaid. This probably should be the focal point of the whole session, and I could easily have spent an hour on this alone. As I mentioned several years ago, the Georgia Community Care Services Program that this slide touches on was very different than it is today. It did not have the same level of funding, and there was always a waiting list. That waiting list of 6 to 12 months meant that anybody who needs help today and got on the list and therefore might get help in 6 to 12 months, it's too late. They've probably had to go to a nursing home by now, because you can't wait 6 months to a year to get help. And so it was, I don't want to say unhelpful or moot that we had the program back then, but it added much less value. Let's put it that way. Today, the waiting list is gone statewide. It still takes a few months to get on because of all of the paperwork and steps in the process of moving through DFACs and all the different levels of analysis to qualify and be approved and actually have a caregiver show up on your doorstep. But there's not a wait based on funding, which is what it used to be. And so it's now much more feasible to do long-term care planning focused on getting in-home Medicaid assistance, because the program is being funded better and being run better. On average, I would say our clients are approved for about 4 to 6 hours a day of in-home help 5 days a week. So that averages about 20 to 30 hours a week, or 80 to 120 hours a month. You should be able very quickly to deduce that that's not designed to be a replacement for nursing care. So you can't go stay at home and have Medicaid pay 24-hour care. Really, this is a program that's designed to be an instrumental component of support for a primary caregiver, so that if we have somebody who's there 4 to 6 hours a day, 5 days a week, that creates a lot more wiggle room and a chance to exhale for a caregiver who's otherwise on the clock 18 hours a day. And so this is a wonderful program. It just make sure you guys understand that it isn't necessarily designed to replace assisted living or nursing home. It's more so designed to delay it. Even though the Elderly and Disabled Waiver Program, letter A, is broken down into source versus CCSP, what I'm now talking about is CCSP, because source is for folks who are eligible for SSI, which is an extremely low welfare threshold. And so often our clients are above that threshold. They just need some extra help. And so CCSP is designed to help them. Time willing or time allowing, I do want to get into a little bit about financial misunderstanding about Medicaid qualification. The good news is that both CCSP and nursing home Medicaid have identical eligibility rules. So I'm not going to have to talk about those separately. I'll talk about those at one time after I've shared a little bit about each of these programs. As you can see under letter A, all these bullet points are the various facets of being able to qualify for CCSP. This one right here, personal support, is a big one. That's where they will send somebody out to help with dressing, bathing, feeding, toileting, transferring, housekeeping, meal preparation. And so it's obviously extremely valuable from that standpoint. Another one, very, very, very important, is what they call alternate living services, but is a personal care home. Why that's a big deal is that if this is at home care and this is a nursing home, and we want something that home is no longer really feasible, but we don't want a nursing home, is there anything here in the middle? This is the assisted living area, right? Well, actually, in the middle, it breaks down into two categories. The places which are bigger, 25 or more beds, those are assisted living facilities. That's where we have no Medicaid. But below 25 beds, these are different. They're smaller, they're regulated differently, and they're called personal care homes. We do have Medicaid personal care homes. I'm not saying that they are exclusive and luxurious, but there is somewhere residential outside of home, short of a nursing home, where somebody can go and Medicaid will help to pay the rent. And so that is the CCSP alternate living services option, personal care home option. Lots of other facets of CCSP that you can see there. All that's in the presentation that can be provided to you, but I need to move on based on time. So for both nursing home Medicaid and CCSP Medicaid, we first have to satisfy these basic eligibility criteria. The applicant has to be aged 65 or older, or blind or disabled. Disabled is kind of a tricky one. As you can see, the third bullet point there is that they must, unless there is a secondary way, but the primary way most people establish disability is through a determination from Social Security. Social Security defines disability based on the ability to work. And so do not make the assumption that somebody who is in a wheelchair. In fact, I literally had a client once who was a quadriplegic who directed his wheelchair through a straw, through blowing into a straw. He was not considered disabled, and the reason was because he was still employed and earned a good living. So it's not necessarily a physical disability, it is an inability to work. In addition, you have to at least be in the setting for at least 30 days. You have to be a United States resident or qualified legal alien. And then you have to meet the medical level of care test. It says see next slide, but I removed that slide based on time. The medical level of care test, which is a big part of that 3 or 4 months it takes to get on CCSP, they're going to look at somebody's medical condition. They're going to look at their cognitive impairment, and then they're going to look at how their physical health or their cognitive impairment impact their ability to perform their activities of daily living and communicate. So if you have either a physical complication or a cognitive one or a combination of them, which impact your ability to dress, bathe, feed, toilet, transfer, communicate, then that's when you meet the intermediate level of care and the door opens to this program. The financial eligibility criteria. In order to qualify for either home-based or community-based Medicaid, you have to have monthly income below $2,742, or you have to use a qualified income trust, otherwise known as a Miller trust. This parenthetical is important. The income test only applies to the spouse who needs help, not the community spouse or the healthy spouse. So if the husband goes to the nursing care facility, his wife's income is not considered part of whether he passes the 2742 test or whether he needs to have a Miller trust. They're looking only at his income. The resource test is different. The resource test, they are going to look at the assets in each spouse's name, and then they're going to apply the limit you see here. For an unmarried applicant, the countable asset limit is just $2,000. It skyrockets up to $150,000 of non-exempt property because obviously the law wants to recognize or acknowledges that we can't have the expensive costs for spouse one leaving spouse two destitute. And so we are allowed to have a much higher asset threshold for somebody who's married. I'm going to skip down quickly to this category or this slide so that we can quickly touch on the spousal income sharing rules, because I don't want to miss this. Georgia has two very important rules that are designed to protect the community spouse. One is that much higher asset limit, and the other one is called the spousal impoverishment income diversion. And so under this bullet point, if you can see letter C, That number, $3,715.50 a month, is specific to calendar year 2023. And that's the amount of money they say the community spouse needs to not be impoverished. And so if husband is in a nursing home and her income is anything less than that, then she can actually receive his income, however much it takes to bump her up to that, which leads to the very, not necessarily very common, but common scenario where in the bullet point I've listed last, if a husband and wife have combined income below $3,715 a month, he can qualify and his bill will actually be free and there's no cost share. Okay, so going back to this slide, which again, you can look at this in the materials if once they're provided to you. This is the transfer test. Now, I have to be careful once again about giving specific legal advice, but most everybody has heard of Medicaid's look-back period. And so all that means is that they're going to look backwards in time up to 5 years to see whether the applicant has made any transfers or sales for less than fair value. And if so, then a penalty will be imposed. This page provides a snapshot of some examples of things that are subject to penalty and things that are not subject. However, there's a big disclaimer here. This is not something that you want to do yourself at home. And I'm not trying to generate business. Just be careful that you run out and do some of this stuff and then apply for Medicaid and then it might go sideways somehow. Please don't misunderstand. This is just for general information to give you an idea that the look back rule, the transfer rule, has lots of exceptions, and there are actually a lot of things that are misunderstood about it. I literally just got off the phone with somebody who made this mistake. Almost everybody has heard that the government lets you give away a certain amount of money per year to your children and spouses and so forth. That number is up to $17,000 a year. That's only relevant to the wealthiest 1/10 of 1% of all Americans who have more than $23 million of savings and therefore owe estate and gift tax. For all the rest of us, Medicaid doesn't care what the IRS allows you to give away. Medicaid penalizes all of those gifts. So be real careful about that. You can look at this sample calculation of patient liability. We've kind of run out of time in terms of 45 minutes, but I do want to highlight that in general, Medicaid does exempt certain important things like someone's home place and a vehicle. There are various other things that are exempt, such that it is not uncommon for a client of mine to apply for Medicaid with a net worth of literally hundreds of thousands or even more than $1 million, and they're already eligible for Medicaid. And so that really gets to the idea that a client must be bankrupt and destitute before help is available. And the fact that that's more of an urban legend than a reality. And so it can be helpful to learn more about how Medicaid views assets and divides them either as exempt or includable before they even look at that $150,000 threshold. So thank you very much. I'm now here to answer any questions.
Dan, thank you so much. That was amazing. I learned so much.
My pleasure.
I will bet that lots of folks are going to be interested in your slides. So if you are interested in receiving the slides, please, I believe all of you heard from me or from Jenny with an email advertising this. If you didn't, and please email us and let us know that you want the slides, and we'll be glad to provide them since Dan has been so gracious to be willing to share that information with us. There's a question, will we be able to email attendees a link to the recorded webinar? Unfortunately, we are not able to do that at this time. But we can share the slides. A second question that came up was for people who are healthy, how should we shop for long-term care insurance policies?
Well, full disclosure, I have an insurance license. I've never sold a policy. I would not try to sell anybody a policy, but because I do have occasion to refer clients to insurance specialists, they are allowed to share a commission with me. But this is not a big part of my business plan, and I'm not encouraging people to call me. Please don't call me about that. However, I do work with several insurance professionals who that's really all they do. My first suggestion for anybody who's listening is to talk with a financial planner. And so if you have a financial planner, then ask them to explore with you whether a given policy is a good idea for you, or whether a long-term care rider on an insurance product might be smart. Just to give you some ballpark numbers, somebody who's unmarried and 58 years old, looking for just a traditional long-term care insurance policy, you should be able to get kind of a middle of the road, not a Cadillac, but not a Chevy Chevette, but a good solid policy for about $4,000 a month, or $400 a year, or $4,000 a year, about $400 a month, let's say. Now we do have what's called a shared policy, which is really neat, in that it's actually something a husband and wife can purchase together. Earlier in the infancy of the long-term care insurance industry, each spouse had to have their own policy, so it was a silo of benefits that nobody could cross. And if somebody died without using those benefits, that silo went to waste. And so now each spouse can benefit from a single silo, which is twice as big. But now we're talking about a far less chance that somebody is going to die without using any benefits, because now we're talking about two people. And we already saw that 70% of people who cross age 65 eventually need long-term care. And so if you've got a shared policy for a husband and wife, the odds are very good that at least one of them is going to be able to utilize. So shared policies represent a big evolution for the industry. That use it or lose it issue. The industry also evolved to address that by allowing people to designate a death beneficiary. So if you get a policy and pay premiums on it for 20 years, and you purchase the death beneficiary rider, which means you pay a couple dollars a month more, then if you die without having ever used your policy, then after an administrative fee, they will refund the premiums to your death beneficiary. So that's another a tool to solve that. And then finally, the hybrid products, those are not long-term care insurance. Those are typically life insurance or an annuity, where you actually can tap into the pool of money if you need long-term care. These are all things which your financial advisor would be able to help you explore. If you don't have a financial advisor, or if you want another resource, you are certainly welcome to reach out to me, and then I would introduce you to somebody who actually does that. When you are researching this, I think it's an important point to make, Laura, is that it's better, in my opinion at least, to work with what's called a non-captive agent. The captive agent works for company X, and they're going to sell you only a product from company X. A non-captive agent is appointed by all of the top companies and can actually help you evaluate which product across all of those companies might be the best fit for you. These products, unlike, for example, Medicare supplemental insurance, have not been standardized. They're not the same with every company. So all of the different companies have different bells and whistles, and they also have different actuaries who count the beans differently as it relates to medical underwriting. And so some companies, the insurance professionals will tell you, are going to be more likely to insure somebody who has a history of cancer 5 years ago versus 6 years ago versus 4 years ago, kind of a thing. So it's not identical across the board, and that's why a non-captive agent can be helpful. And I'm happy to share some of those names if anybody wants.
What a great answer. Thank you. I think relatedly, there was a question about how do we know what my mom's policy covers? So she's been told to contact the company providing it, but what she reads in the policy is different from what the company is sharing with her. There's
Great question. And once again, I would say that is not something that I would personally handle, but I do have a couple of resources who I call advocates. Basically somebody with an insurance background who is willing to go to bat on behalf of the family. I hate to say against the insurance company. This is not a lawyer suing them for breach of contract. This is basically an advocate who can get on the phone and use all the lingo and acronyms and basically convey to the person on the other end of the line, look, we know what we're talking about, so quit giving us the runaround, and possibly even file an appeal, because policies will have an appeal process. At some point, it might be necessary to hire a lawyer to sue them, but more so, I think this is a better scenario to not get a lawyer and instead get a patient advocate who can help you understand what your policy covers. And if you think your claim is being denied incorrectly, can help you maybe refile it and recategorize it, get different medical records to support it. You know, there's all kinds of different ways to do that.
Thank you. One last question that we have time for is somebody wrote in, I recently learned that my mom may be eligible for VA aid and attendance because my late father served during Vietnam and he's passed. How do I find out if that's true and how do I start the process?
So I'm going to pull up something for your audience and they can do a screenshot if they want.
You're so great.
So what I've just done, let me go ahead and pull this up and share it, is I just ran a Google search for VA periods of war. You can see up here. That takes me to this page. And as you scroll down, it's going to talk all about the different requirements. But the one that I want to highlight is right here. How do I know if I served, or in this case, the husband who's passed served during wartime? The date for all of the wars, believe it or not, there's a specific day that each war began and ended, going all the way back to the Mexican border war in 1916. And so why that's a big deal is all this stuff in parentheses related to Vietnam. Other than this parenthetical, which I'm going to touch on in a second, there's no boots on the ground requirement for aid and attendance. What that means is if the veteran served in Kansas or Germany or wherever, they did not have to go to Vietnam. I'm sorry, they didn't have to go to and get shot at or be in combat to qualify for this benefit. I shouldn't have said Germany, that's a bad example. If you did go to Germany, you were in country and probably were in combat. So they could have never left the United States. The point being, you didn't have to have your boots on the ground in the theater of war, except for this one window of time between the end of the Korean War and the beginning of the Vietnam War. Anyone who knows history knows that there was all kinds of CIA and other activity over there that we don't really know when I don't really know when the war actually started. All I can tell you is that if you're applying on behalf of somebody who served before August 5th, 1964, the veteran had to have gone to Vietnam. After that date, random date for whatever reason, the boots on the ground requirement goes away. So the answer to this person's question, I think the first thing they need to look at is did this person serve during wartime? And if it was in the window of 55 to 64, did they ever go to Vietnam? Other than that, I'm going to Google the next thing, Georgia. The Georgia Department of Veteran Services. If you Google Georgia Department of Veteran Services field offices, this is a state of Georgia agency, not the VA. And they are a VSO kind of like the Knights of Columbus or other VSOs. But they are extremely capable and passionate and knowledgeable about the VA wartime pension, and they can actually help you with the paperwork. The VA has a very strange law which says that an attorney cannot charge a fee for assistance with prosecution of the initial application. So although I am a VA accredited attorney, I don't actually prepare and file VA applications like I file Medicaid applications. Having said that, all you have to do is go to this website, scroll down to your county, click on your area, and then most of these pages will include the contact information for, let me see if I can find the one. The contact information for somebody there. Here it is, the Canton office. So this woman, she's probably going to kill me that I highlighted this, but if you ever have a chance to talk to Rita Barnhart, you're talking to the person who knows more about aid and attendance than anybody in the state of Georgia, including all the lawyers. And she's a huge advocate and just a super wonderful lady. Probably talk with somebody on her team, but the point is they can actually help you fine tune the eligibility questions you have and even help you file the paperwork if you need that help. So with that, I will stop sharing. I'm glad to, I know that you guys have a time limit, but if there are other questions, I'm glad to try and answer them. Otherwise, I'll turn it back over.
Dan, thank you so much. This has been just phenomenal. Absolutely fantastic. Really, really appreciate you being here. I have already gotten several emails requesting the slides, and we're definitely going to have you back if you'll come back to see us.
I'm glad to share information as many times as you think it would be valuable. So feel free to follow up anytime. And Jenny, thanks for the opportunity.
Thank you so much.
And it was a delight to have you. You are so talented at what you do. Thank you so much.
My pleasure. Y'all have a blessed day.
Bye.
Bye-bye.
All right. Bye, y'all.